Assalamu alaikum. So I started a series on my Facebook group MRCPCH for beginners. It is a recall series in which I'll be posting some recalls every week from one system. Okay. So this week I have posted recalls from genetics, and I'll be discussing one of those recalls today. Even though you guys have already commented the right answer, but I felt the requirement to actually discuss this particular topic because it is equally important for both FOP as well as the FOP task as well as AKP exam. Okay, so let us discuss what happens. So we have a 1 week old baby boy presenting with seizure, and on examination there was a pansystolic murmur. Whenever a neonate presents to us with afebrile convulsion, that is one attack of afebrile convulsion, we'll have to keep two things in mind. Either it is due to hypoglycemia or it is due to hypocalcemia. So we don't know yet. We'll be discovering it more. So either the seizures are due to hypoglycemia or hypocalcemia. Along with that, there is a pansystolic murmur. Now, in this particular recall, the location of the murmur isn't given, whether it is in the upper left sternal edge or lower left sternal edge. But we all know that pansystolic murmur is clinically caused due to ventricular septal defect. Therefore, we have a neonate presenting to us with seizure and a congenital heart disease. Clinically, we have diagnosed it. Now, we do have some investigation findings. Let us see. So, according to the investigation findings, calcium level is low. Since the calcium level is low, I can now tell this baby was having seizures due to hypocalcemia. So, a neonate presenting to us with hypocalcemic seizure and a congenital heart disease. Let us look at the rest of the findings. We have hyperphosphatemia. Phosphate is slightly above normal. Parathyroid level is reduced and alkaline phosphatase is increased. So, we all know the homeostasis, that is calcium is basically maintained by the regulation of calcium is done by the parathyroid hormone. Parathyroid hormone, when it is reduced, or in this condition we can say that it is decreased, as a result basically parathyroid hormone has two functions. Among many other functions, the main two function is that it increases the reabsorption of calcium and causes excretion of phosphate. So since parathormone level is low, there will be decreased reabsorption of calcium. At the same time, decreased excretion of phosphate, which will lead to hyperphosphatemia. All right. So this is basically, this entire situation is actually clinically called as hypoparathyroidism. So this is a case of hypoparathyroidism. If I look into only the investigations, but when I look into the investigations along with the clinical findings I've got here, that is hypocalcemic seizure with the pansystolic murmur, this is actually diagnosis of Digeorge syndrome or Digeorge syndrome presenting to us with hypoparathyroidism. Okay, so the right answer, what is the diagnosis and name the endocrine association? So the right answer is hypoparathyroidism in a case of Digeorge syndrome. So we'll be studying about Digeorge syndrome today. I've prepared some notes here. So this is Digeorge syndrome or Digeorge syndrome, and it is also known as 22q11.2 microdeletion syndrome. I'll be telling why it is called 22q11.2 microdeletion syndrome. So this is a picture of a child with Digeorge syndrome. I've taken it from Google. You can see he has small eyes, hypertelorism to an extent. Nothing else I could understand from this particular image, and there is also dullness of the face. Now what happens, what is the pathophysiology? Whenever we are studying a condition, make sure you study in this particular order. You study the pathophysiology, okay, or the cause. You study what are the clinical features, what are the investigation, what is the management plan, what are the complications or associated disease, if any. If you study in this way, you will be able to remember it for a very, very long time. Okay, it is very important. And if you're someone who likes in building the basics, then this is your way. Along with that, you may add recalls. That is, although time consuming, but is very beneficial in the long term. So just like how I have arranged this particular PDF. So see here, they said 22q11.2 microdeletion syndrome. What is this 22? So basically what happens in chromosome number 22, Q indicates the long arm of chromosome number 22. A portion of this particular chromosome will be deleted. Okay. So what happens when it is deleted? Each portion of the particular chromosome actually encodes for genes, and these genes but then encodes for many um, proteins which help in expressing certain characteristics. So what happens is that let us study now the pathophysiology. So this 22q11.2, this particular location, that is this particular location in the chromosome, encodes for certain genes. And these genes, one of the genes is known as TBX1. All right. And this encodes for genes which basically will translate into proteins. And these proteins are actually only a few million proteins. That's why it's known as microdeletion. If it is above 5 million, then it is commonly known as deletion syndrome. But this is, since why it is called microdeletion, is that only a few million base pairs that leads to the protein translation is deleted. So what happens? This usually encodes for some genes. And these genes, also known as the TBX1 gene, this particular gene is responsible for the development of the third and fourth pharyngeal pouch. Commonly, the third pharyngeal pouch will differentiate or develop into the thymus, which is the organ for where the T cell matures, and the fourth pharyngeal pouch matures or develops into the parathyroid gland. Now, what happens in case of Digeorge syndrome is that this particular portion of the gene is deleted. As a result, this particular gene is not produced. Therefore, no development of the third and fourth pharyngeal pouch. Therefore, no development of thymus and no development of the parathyroid gland. So this child will have thymic aplasia and parathyroid hypoplasia or aplasia. Why we say hypoplasia is that basically fourth pharyngeal pouch, it develops into superior parathyroid gland. So not the entire parathyroid gland, basically superior parathyroid gland. So child will suffer from parathyroid hypoplasia instead of parathyroid aplasia. Okay. So this is the pathophysiology of Digeorge syndrome. Now let us see how a child with Digeorge syndrome will present to us. That is, what are the clinical features, what are the signs and symptoms. So they do have some dysmorphic facial features, which are, you can see, cleft lip, cleft palate. So they commonly present with cleft lip, cleft palate. There is usually small eyes with hypertelorism, low set ears, small face as well. These are the commonest findings. Along with that, you will see there is history of recurrent infection. Now let us study why there is history of recurrent infection. We did study, right? Due to failure of development of the third pharyngeal pouch, the thymus will not be developed. So there is thymic aplasia. And thymus is the organ where T cell maturation takes place. Since thymus is not developed, there will be no maturation of the T lymphocytes. As a result, it will lead to T cell deficiency, ultimately leading to immunodeficiency. Okay. Second one is that the child will have hypoparathyroidism. And why is that? So the fourth pharyngeal pouch fails to develop into superior parathyroid gland. As a result, there will be decrease in the parathormone. So when parathormone is reduced, there will be decrease in the calcium, and that will lead to hypocalcemic seizure or tetany. This is the reason this children or this particular child, 1 week old baby boy, presented to us with seizure. So child can present to us with hypocalcemic seizure. The third association is congenital heart disease. This condition is very commonly associated with congenital heart disease, such as truncus arteriosus, tetralogy of Fallot, and ventricular septal defect. So, in summary, what we get is we get a child with cleft lip, cleft palate, and other dysmorphic facial features, along with seizure and history of recurrent infection and congenital heart disease. Please keep all these points in mind because everything will be asked in the recall in different formats. They'll just change the framing of the sentences, otherwise, the topics are similar. That is, they'll take Digeorge syndrome itself, but sometimes they'll ask what is the endocrine association. Sometimes they'll ask about the that is immunodeficiency. Sometimes they'll ask you about what is the cause of the seizure. Okay, so what is the common investigation we do in case of microdeletion syndromes? That is, in case of Digeorge syndrome, we usually do the fluorescence in situ hybridization, also known as FISH testing. Now, management. Now, for the management, what happens is that this is a genetic disease. As such, there is no particular treatment for it, but it is manageable. How it is manageable is that we can do symptomatic management. We can repair the cleft lip, cleft palate through surgery. Congenital heart disease, to an extent, can be managed by medical management and then referred to surgery, cardiac surgery. Then we have immunodeficiency. If the child is coming to us with immunodeficiency, we can treat the child for the infection, and as well as for the hypoparathyroidism, we can give the symptomatic treatment, that is give him calcium supplementation. This is how we'll manage the Digeorge syndrome. Okay, so this is a very very common topic in exam. I remember there was one question in my exam where they said a child has come to you. I'll discuss the recall here. It was something like that. I can't exactly remember the framing. It was like a child has come to you, he's 2 year old, and he has come to you with seizure. He has history of repair of cleft palate in in early infancy, and now he also has a murmur. So if you see, I have a child now presenting to me with seizure. It could be due to hypocalcemia. Along with that, there was a history of repair. So this one was actually the most important point I had to keep in mind, because the history of repair of cleft palate, the only syndrome which is very commonly asked in exam with cleft lip or cleft palate, is actually Digeorge syndrome. So history of cleft palate repair, along with that, a congenital heart disease. So this is definitely a case of Digeorge syndrome. All right. So thank you, everybody. I hope this was helpful, and I'll try to post more videos on recalls. Thank you, everybody.